Bore pawb, croeso i'r seminar awe, diolch am ddod. John Drake dwi, cyfarwyddwr uned atal trais. So good morning everyone, welcome to the webinar and thanks for coming today. I'm John Drake and I'm Director of the Wales Violence Prevention Unit. So very warm welcome to all the people that have joined us from across the UK today. I'm very pleased to welcome you today. What we're going to do today, I'm just going to run through a few housekeeping issues for you, just to help the webinar go well. And these are normal. I'm sure many of you have been on webinars over the last few months, but just ask if you could all keep your microphone on mute and keep your video turned off unless you're presenting. We're going to have a question and answer session later, and that's all going to be done via the chat function. So if you could post your question using the chat at the side of the toolbar, and I'll answer the question. I'll ask the questions rather. I won't be able to answer all of them, and I'll ask the questions of the presenters for you on your behalf as we go through them. Okay, so just to say as well, the slide and resource pack's going to be available for everyone after the webinar as well. So by all means, make notes, but they will be circulated afterwards as well. So just to run through today, so it will be finishing for 2 p.m. promptly. So we've done introductions of myself from the Wales Violence Prevention Unit. I'm the director. Next up, we've got Dr. Lisa Jones from Liverpool John Moores University, who's going to be talking about the costs of violence to the healthcare system in Wales, so and the research that's been undertaken. We're joined by Medina Johnson, who's the Chief Executive of IRISi, who's going to be talking about that particular intervention, followed by the NHS Violence Prevention Team, Fionn and Vicky. And then we've got a question and answer session. So we've tried to sort of structure today that there's a mixture of some of the theory and research, but then some of the practice that we believe is helping to prevent violence across Wales as well today. So I hope you enjoy the seminar. Just a little bit about the Wales Violence Prevention Unit. We're a very new team. Most members have only been with us for less than a year. Our mission as a team is to prevent all forms of violence across Wales through using a public health approach. And we do that in a number of ways, one of which, and this diagram probably explains it quite well, in that on the right hand side you can see there's providers and commissions. So particularly in South Wales, we commission providers to actually deliver a service across on the streets of South Wales, and you'll see that today we've got Fionn and Vicky for one of those from one of those interventions presenting to you today. We've got a small core team who are funded by way of a Home Office grant. They're the team in the middle who work full-time with the unit, but it's important to say that the vast majority of those members, even the full-time members, are seconded from the host organisation. So we enjoy in Wales a huge sort of buy-in from public and third sector agencies in terms of seconding a staff. So we get about 3 times the return on investment that we spend in terms of grant on staff. And the reason simply that we believe that to take a whole systems approach to violence prevention, we need a really good mix of different backgrounds, disciplines and organisations to help us to do that. On the left hand side, you can see we also have associate members. So these are people with day jobs who basically partner with us to provide a much wider violence prevention network across Wales. And again, links into my earlier point about needing to take a whole systems approach. We need lots of different backgrounds, experience and skills. So we have around about 42 members in total. But as I say, we're a very new team. We've been around for most of us less than a year. So on the next slide, I just wanted to describe to you a little bit about what a public health approach to violence prevention actually means. So as you can see here, taking a public health approach means that as the first step, we really seek to understand the cause of the problem. So that might be through data, through violence surveillance, as it's called, through analysis. But the point is we use an evidence-based approach, and this is sort of the root to that public health approach. We then identify what the risk and protective factors are. So what are the causes, for instance, of violence? And then we develop and evaluate interventions. So again, some of those examples you'll hear today. In particular, we look to evaluate those interventions and really work out what works with a view to scaling them up on a wider basis. So many of the sort of initiatives that are developed as good practice, and I believe you'll hear from 2 such examples today, it would be fantastic to scale those approaches up, wider across Wales as well. So in terms of the next slide, just in terms of some of the highlights from research that's been done around the costs of violence to the NHS. So as part of our mission to prevent all forms of violence in Wales, we commissioned the Public Health Institute, and in particular Liverpool John Moores University, to research the costs of violence to the healthcare system in Wales. Now, Lisa Jones, who led the research, is presenting today and is going to discuss the findings of that research in a lot more detail. But I'd just like to highlight a couple of the key points and recommendations from that research. So firstly, there is a direct cost on the healthcare system in Wales, the NHS, on violence. So there is a direct cost of nearly £50 million a year. So that's in terms of the cost of treating violence victims, for instance. So Lisa will talk a lot more about that. But the other point is that there's secondary costs as well of nearly 160 million a year. So that's through long-term health-related costs, exposure to things like ACEs, and we use that as a sort of proxy measure of that cost. So in other words, violence is costing the NHS a lot of money each year. Now, of course, the whole aim of the Violence Prevention Unit is to prevent violence because it's the right thing to do. We don't want people hurt in Wales, but there is actually a cost as well to violence, and that's what we want to cover in more detail today. So importantly, some of the findings from the research showed that a whole systems approach, as that first step of a public health approach, needs enhanced information sharing. So we need to be sharing data, we need to be analysing it, we need to be looking for where the problems are and looking across all agencies for that. So in the case of the NHS in particular, that could be getting really good quality data from accident and emergency departments, for instance, following the sort of ethos of the Cardiff Model. It's also about investing more in community-based programmes, and again we'll talk about 2 successful ones shortly, but how we then scale those up, and importantly, of course, preventing adverse childhood experiences. So I'm not going to talk for any longer. I'm going to hand over to Lisa now, who's going to take you in a lot more detail through the costs of violence to the healthcare system in Wales. So Lisa, thank you.
Hi everyone, thanks very much John for that introduction. So hi, my name's Lisa Jones and I'm based in the Public Health Institute at Liverpool John Moores University. So we were commissioned to undertake a piece of work, as already been mentioned, looking at the costs of violence to the healthcare system in Wales. And just as a bit of a background to this, the costs of violence to the NHS in England and Wales had previously been estimated at around 2.9 billion back in 2012, but before this piece of work was done, we didn't have an up-to-date estimate of the costs of violence, and we didn't have this sort of specific information for the costs of violence in Wales. So if we have the next slide, please. Thank you. So the purpose of the work was to demonstrate the size of the problem and to be a useful starting point for the VPU, and to also provide the evidence needed to influence decision making and to underpin advocacy for investment in violence prevention, so to make that argument about investment. So our overall aim was to identify and measure the costs of violence to the healthcare system in Wales, and we did this using cost of illness methods, and I'll talk through in a bit more detail about the methods we used in the next few slides. And these are established methods for demonstrating the economic burden, and they're used across many different kind of healthcare burdens, healthcare issues. So through the work, as I'd mentioned as well, we wanted to make the case for investing in violence prevention. So we wanted to provide that evidence to make that argument that some of the burden on the healthcare system could be avoided if we invest more in prevention. Have the next slide, please. Have the next slide, please. Thank you. So this slide shows the stages we worked through to apply the cost of illness methods. In the first phase, we carried out a literature review, and that was to identify published studies that have examined the cost of violence. And we used that evidence to build a framework and an analytical approach for the next phases of the work. So we kind of wanted to draw on how people have looked at this issue in other cost of illness studies. And we went through then in the next phases of the work, working out what data we needed and which costs to that data. And it was only at that point that we were able to move forward to calculate the cost. So there was quite a lot of preparatory work that went on to kind of build the framework and the different phases for the work. And then to make the economic case for violence prevention, we collated evidence that showed the return on investment or cost savings that were associated with violence prevention interventions and activities. Thank you. So this slide shows the results of our literature review. We only found 2 cost of illness studies that examined violence in general. Most of the studies that have been published, the ones that we identified through the literature review, have looked at particular types of violence. So that posed a little bit of a problem for us because we weren't looking at specific types of violence. We had to consider this broader idea of how we look at violence more in general. We had hoped to look at the different types of violence, but we weren't actually able to do that with the data that we had available to us. And there's a bit more detail that we provide in the report around that. And as previously mentioned, we used the findings from the literature to build our framework for the costing work. So just move on to the next slide. Thank you. So our final framework involved us identifying and costing both the short-term health-related costs for violence, so that included interpersonal violence and self-directed violence. And as John mentioned in his summary of the work there, we also identified and costed the long-term health-related costs of violence, and we used adverse childhood experiences as our proxy measure for the long-term effects of violence. And as the previous slide, we complemented the costing work by collating evidence to make the economic case for violence prevention. Have the next slide, please. Thank you. So this slide breaks down the different cost components that we identified. So for interpersonal violence, we were able to cost A&E attendance and also those A&E attendances that arrived by ambulance. We looked at emergency admissions and we included costs associated with counselling and also the use of primary care for follow-on care. For self-directed violence, we had fewer components that we could use to build up our costing methodology here, but we were able to use published data to estimate the number of self-harm episodes presenting to A&E. And there's a lot more detail in the report about how we built the methodology in these areas. It's provided in a bit of detail in the report that I won't go into in the presentation today. Can I have the next slide? Thank you. So this shows the costs that we estimated for interpersonal violence and self-directed violence. So the costs for interpersonal violence were estimated at around £39 million, and you can see here how the different cost components contributed to the total. So the bulk of the costs there were around the hospital stay, but also linking in with the counselling. For self-directed violence, the costs are lower because we had fewer components that we were able to include in our calculations, but we estimated there a burden of around £7 million, and that was for the in-hospital stays, A&E and treatment. This slide shows a further breakdown of the costs for interpersonal violence from the first column on the previous slide. So it shows how the individual cost components of a visit to hospital contributed to the final total of the £14 million for that particular cost component. And we can see here that it was really the treatment for physical injuries that contributed the bulk of the costs there. Can I have the next slide? Thank you. So as I've mentioned, we did also look at the long-term consequences of violence using ACEs as a proxy measure. And we were able to do this because we had good data that we could draw on from Professor Mark Bellis's work on looking at the population attributable fraction of ACEs. So using this population attributable fraction approach, we determined the costs associated with 3 causes of ill health. That was anxiety and depression, harmful alcohol use and illicit drug use. And we did this by applying the population attributable fractions from the published work to the healthcare costs for these 3 areas. And again, a full breakdown of how the costs were calculated is provided in the full report. If I could have the next slide. Thank you. So this shows the costs associated with each of the 3 areas. And in total, as John had already mentioned, we estimated that the long-term costs were in the region of £160 million. And you can see the breakdown across the different areas here. Have the next slide, please. So it's just important to note that a limitation of the cost of illness approach is that the estimates they produce of the economic cost of violence shouldn't be used by themselves as a means for priority setting and as an influence on decision making. We need to use them alongside the results of economic evaluation. And economic evaluation, based on Drummond's definition, is the comparative analysis of alternative courses of action in terms of both their costs and consequences. And there's a lot more detail about this in the report, but there's a growing body of evidence that we can draw on that supports both the effectiveness and the cost effectiveness of violence prevention interventions. So we wanted to draw on this evidence to really build and make our case for investing in violence prevention. And I'll just talk through 2 examples over the next slides. So the first example we have is the Cardiff Model for violence prevention, sharing of information and data. And that model has been shown to substantially reduce costs associated with violence. And a published evaluation showed that £82 in benefits, pounds spent on delivering a programme. So we know that violence prevention programmes can deliver benefits. Have the next slide, please. And the second example is of the IRIS programme, and that will be discussed in more detail in the next presentation. But briefly, the published evidence for the IRIS programme showed that it was both cost effective from a health service perspective and also cost saving when a broader societal view of the impact was considered. So that was that the programme accrued benefits both inside and outside of the healthcare system. So as shown on this slide, the published evidence showed that the programme was associated with societal cost savings of £37 for each female patient in participating primary care practices. And I'll just move now to some of the key conclusions that we drew from the work. So the main conclusion that we drew and that we wanted to make the case for is that violence is preventable. And alongside there being a clear public health argument for investing in violence prevention, as we'd shown through the work that we'd done in the report, there is also a case to be made on economic grounds. And just to note as well that there is a substantial body of work and expertise directed towards violence prevention in Wales, and what we provided in the main report was strategies and drawing on evidence from the literature about strategies that could be leveraged to make the case for further investment in violence prevention. So just bring up my final slide. So just say thank you very much for your time, and I've just provided links on the final slide there to the full report and the infographic summary of the work, and they're available from the VPU website. And please do get in touch if you'd like to discuss the work further. And thank you very much.
Thanks so much, Lisa. So I'll hand over now to Medina, who's going to talk to us about IRISi.
Thank you, John. Hi everybody, thank you for having me at the meeting today. And I notice a lot of names that I recognise in participants at the meeting today. So if anything I'm saying isn't quite up to date in terms of Welsh statistics, colleagues, Amy, Julie, Nicola, Jackie, please correct me in the chat box, and I'll explain what I mean by that shortly as I go through. So what I'm going to do for the next few minutes is just talk through our experiences as an organisation that developed an intervention, an evidence-based intervention, and the way in which we support areas to commission that, and the benefits that we see in terms of improvements for healthcare providers and people accessing the healthcare service. So next slide, please, Bryony. So as an organisation, IRISi is quite young. We've only been going for 3.5 years, but before that, we spent 10 years developing for 3 years an intervention, and then for the subsequent years working with areas to deliver that intervention, taking it from research into the real world, if you like. So as an organisation, we have a very clear mission. So we want to see that gender-based violence, domestic abuse, VAUDA-SV, whatever we're calling, whatever we're talking about, is consistently recognised and addressed as a health issue. We know that the response to violence across the board isn't the responsibility of one organisation or one sector, which leads us into our mission. It has to be a partnership approach. And all the work that we do is about encouraging partnerships between our colleagues in health and our colleagues in specialist frontline services working together, because we feel it's only by these two very key specialisms working together that we can make substantial and positive improvements and impacts for not only practice, but for people's lives and in terms of violence reduction. Have the next slide, please. So we developed through a randomised control trial that ran from 2007 to 2010, a programme called IRIS. And IRIS stands for Identification and Referral to Improve Safety. And in a nutshell, it's a general practice-based domestic violence and abuse training and referral programme. Now, I've put in here what about VAUDA-SV, because I know within the Welsh context we talk more widely. We talk about violence against women, domestic and sexual violence. And we're seeing very much across the whole of the UK that combination now of domestic abuse and services and work coming together. We're very aware of that, and we are testing out and piloting an integrated programme of work that integrates both the response to domestic abuse and sexual violence within general practice. We're testing that in 2 areas at the moment, and I'll be able to bring more updates around that over the coming months, but I'm not going to focus on that today. I'm focusing on our domestic violence and abuse programme. The 5 core things for IRIS, what we have an evidence base for working, are what we call our 5 R's. So we want to encourage, when we're working with practitioners, them to recognise when patients are affected by domestic violence and abuse, to ask them about it and conduct a high-level, simple risk check. We're not talking about a dash, we're not talking about a full safety check or safety assessment, but we're talking about a high-level risk check. We then want our clinical colleagues to respond to that in an understanding, validating way, to offer a referral, whatever that looks like and however that's appropriate for the patient at the time. And within IRIS, that's a referral to a named worker. I'll talk more about that in a moment. And then we want the clinician who has gone through these steps to make a record in the patient's electronic medical record of the consultation, of any discussion, a disclosure if there has been, so that that is very safely and importantly recorded in the patient medical record. So we talk a lot about the 5 R's. We know that this approach through our evidence base increases identifications within the patient medical record and subsequently referrals into specialist support for patients affected by violence and abuse. We know that it improves clinical practice, and we also very importantly know that it improves the health and quality of life for patients. Can I have the next slide, please? So here's what the model provides in terms of inputs. So training is offered. The two key people leading the programme in any area that commissions the IRIS programme are the advocate educator, and we have Amy, I can see in the meeting today, who's a long-standing advocate educator working in the Cwmtaf area. We have a clinical lead who is our local, usually general practitioner, who leads and supports and provides peer support for colleagues who receive the training. And again, at the meeting, we have one of our longest standing clinical leads, Dr. Jackie Gantley, who works across 2 of our 3 areas for IRIS in South Wales. We develop with local areas an enhanced care pathway. So what the IRIS model offers is additions and enhancements to what exists already. We're not about steamrolling, replacing, or suggesting any different practice, especially in terms of safeguarding. That is as it stands, but we feel that the IRIS model offers an additional route into support and a direct route into support for patients who need that. We promote clinical inquiry, so we're not talking about screening or routine questioning, but when there's a clinical reason to be asking a patient about domestic violence and abuse, we're promoting that there's a low threshold for doing that. I mentioned before about validation, risk assessment, and the need to document. And practices are also provided with health education materials, posters and information cards for their patients and staff members. We know in terms of outputs, as I've said, that this increases identification and referral. And what is offered to the patients through the advocate educator is emotional and practical support. And we evaluate, monitor and collect data from every site on a quarterly basis, which we then present in a national annual report. Our latest one was published a couple of weeks ago, and that's available on our website, the link for which is on my final slide. We've also, just picking up on what John mentioned in his introduction and what Lisa also mentioned about the importance of data, we've also started some conversations very recently with the Violence Prevention Unit facilitating today about how we can helpfully share any of the anonymised data that we collect across Wales to enhance and support the data work that you're doing locally. In terms of outcomes, the most important part of the model, we see outcomes across 3 levels. For patients, in terms of quality of life, health impacts, reduction in abuse and an increase in safety, all of which are incredibly important and valuable. We see improvements for our primary care colleagues who for many years have been saying, you know, we want to offer support, we want to know how to best respond to patients, but we just don't really know how to, so we don't ask because we don't want to open Pandora's box and not know what to do with what comes out of it. So what the programme offers is a way to provide more holistic care to patients, and it also supports and provides continuing professional development for the primary care professionals themselves. And in this way, the domestic violence the practices become domestic violence aware and better resourced. Next slide, please. So here's what we found from many years ago in our research trial, randomised controlled trial. So we have an evidence base that, compared with practices that didn't have IRIS, in those where there were the IRIS programmes running, there was a 6-fold increase in referrals to a specialist service, and behind that was a 22-fold increase in a discussion about domestic violence and abuse and about a referral. So the difference there is that the 6-fold increase in referrals is actual referrals being made directly to the advocate educator with a name of a patient and a contact number and a request for direct support. And the 22-fold increase we were able to demonstrate by interrogating patient medical records, and to know that the GPs, practice nurses, members of the practice team had noted in the patient medical record that they'd had a discussion about domestic violence and abuse. There may have been a disclosure, but at that point the patient wasn't comfortable to, or didn't feel it was the right time to follow up with a referral. But what we also know is that very often, once that initial door has been opened and once the initial conversation has had, many of those conversations then later down the line turn into for direct support and direct referrals. We also know that in practices with IRIS, patients are 3 times more likely to have a recorded identification in the medical record. And this is really important for many, many reasons in terms of perhaps court cases, child contact, housing access, and of course, to be able to provide ongoing good medical care in an ongoing way for the patient. Lisa touched on some of our cost effectiveness information, and we also see positive cost effectiveness in terms of both the NHS and in terms of society within a controlled trial. We are testing out at the moment, and again, colleagues who know me on the call have heard me say this for quite a few months now. We are testing out a real world, if you like, not a research way of looking at cost effectiveness, cost saving and cost per quality adjusted life years using an interactive tool that our colleagues running the IRIS programme in sites will be able to use. So in a very simple description, colleagues locally will be able to enter in the number of practices they've trained, the patient population, the number of referrals they've received, how much the intervention is being cost to deliver at the moment, and that will all be processed and information will come out the other end of the data to show, is it cost effective, is it cost saving, is it providing cost per quality. When we tested this in 6 areas, not in Wales, but 6 areas of England that have been running the IRIS programme for 2 years or more, in 5 of those areas, all 3 of those measures were positive. So they showed cost effectiveness, cost savings, and cost per quality adjusted life years. And in the 6th area, they showed positivity on 2 of those 3 metrics. So we hope once we've tested this, which is it's out for test with 3 sites at the moment, we'll be able to make this available so locally areas will be able to run their own cost effectiveness checks. Next slide, please. I'm struggling with the next slide, Bryony. I'll have a look at a couple of the questions just while we're getting the next slide up, if that's okay. So an initial clinical inquiry happen, how does this happen with hidden signs or symptoms? Well, when we're training practices, we're training them to recognise what hidden signs and symptoms might look like. So we know, for example, that many patients affected by domestic violence and abuse will present with will make repeat presentations. So they might attend with depression, anxiety, chronic backache, bad headaches, sometimes things that have been tested for medically, but the tests have come back either inconclusive or negative. And what we want clinicians to do is then to ask behind that. So to ask about, tell me what's happening for you at home. Who do you live with? Who have you got at home? How's that going? Do you work? What sort of work do you do? How's that going? Really starting a very broad conversation that can then be funneled down into, is anyone hurting you? Might this be because things are quite difficult for you at home? And that's, you know, quite a very swift way of what we spend sort of 2-hour sessions training and working with our clinical colleagues to provide. Another question is about were self-referrals recorded that resulted from domestic abuse discussion with the patients. This was quite challenging during the trial. We tried to do this, but it was quite difficult to separate out where very often the referrals came from. So what we report on in terms of the trial data is the actual referrals that came into the advocate educators. So I was one of the advocate educators in the original trial. And so if I had the actual referral on an email, via fax, on a piece of paper in my hand, that's what counted, and that's what led to the 6-fold increase statistic. We didn't count anything that was self-referrals or different from that. We do have that information, but we haven't reported fully on that. I'm not sure whether oh, here we go, the next slide, thank you. So this sort of answers part of Julia's question earlier as well. So in terms of the health impacts, they're very wide and very far-reaching. So any clinicians on the meeting will recognise these as very common symptoms that patients will be presenting with in general practice, consultations on a daily basis. And the one that I'll dwell on for that really is the gynecological problems, because we know that women affected by violence and abuse are 3 times more likely to see issues around gynae than patients not affected by domestic violence and abuse. Next slide, please. So we're not going to show this video. We made that decision when we were preparing for the webinar, but you will all get the slide decks after the meeting, as John suggested. And what I'd encourage you to do is to please do click on and listen to this video and narrative from Emma, a woman from Wales who very bravely and courageously wants her experience to be shared and used as a sort of learning tool, really. Emma was in 2 violent relationships, both very different. She suffered very wide and far-reaching health impacts as a result of this that went on for many, many years. And she was never offered an opportunity, never asked about domestic violence and abuse until a clinician in her IRIS-trained practice picked up on some of the issues that she was experiencing, her ill health, particularly her mental ill health and her low mood. And then literally decades of abuse came out in one consultation, and she was referred into Amy, one of our advocate educator colleagues who's on the meeting today. And so I'd encourage you to listen to that, just as a way of really recognising that when we talk about early intervention, because we want to, of course, be offering people an early opportunity to disclose and discuss what's happening for them, it doesn't always mean it's within the early days of the abuse that they're experiencing. It might mean it's the earliest opportunity they have had in their life. Unfortunately for Emma, this was many years down the line. But the more we talk about this as an issue, the more aware we are of this as an issue, the earlier we can prevent it, respond, recognise and do something about it. Next slide, please. So I'm not going to go through all of these now, but here are some words again from Welsh women who've been supported via our IRIS programmes in Wales. And I think what's interesting when you flick through these is how key that partnership is between health and the third sector. So at least 2 of the women quoted here are talking about the fact that their GP recognised case when the woman herself didn't recognise what was going on for her, and the support that she was able to access then really helped her. When we're talking about things like that first quote, "She literally changed my life," and that third quote, "I would never have got through without it," we know that many of the women that are seen affected by violence and abuse are suicidal, have tried to self-harm. So, you know, we're talking very often at the very sharp end of people feeling very desperate and very anxious. And the earlier in the course of violence and abuse that we can prevent this, the better. Next slide, please. So this is a slide looking at the national referrals that we've seen from when we first started IRIS as a commissionable programme way back in 2010. The programme is actively running in 36 sites at the moment. We've gone from 2 advocate educators to 81, from 1 clinical lead to 59, from in the research days having 24 fully trained practices to over 1,000, and to having now, well, this was as at March this year, 20,500 women referred in directly for support. So if we then multiply those up in terms of the number of women who've actually been able to have conversations, had that offer of a conversation from their clinician, we know that many tens and possibly hundreds of thousands more people have had the opportunity to talk about what's going on for them. Next slide, please. And next slide again, please. So this is the slide where I feel slightly fraudulent, because I want to make really clear that IRISi is the originator of the IRIS model, and we're the facilitator for local areas. We support commissioning, we train the local colleagues who then go on and deliver the programme. So all of the information that you can see here is not down to IRISi, it's down to our fantastic local partners who are making this happen locally and on the ground. So IRIS is running at the moment in 3 areas of Wales. Cardiff and Vale is our longest running site. It's been running for 5 years now, a partnership between Bowso and Cardiff Women's Aid, and our clinical lead, Jackie, who, as I mentioned, is on the meeting today. And the numbers really speak for themselves. So in those 5 years, we've seen an average of 250 referrals per year, whereas before IRIS, we were seeing fewer than 5 referrals coming from general practice every year. The second site that set up and was commissioned to run IRIS in Wales is in Cwmtaf, and that's run between a partnership of Safer Merthyr and Rhondda Cynon Taf Women's Aid. And that has seen over 700 referrals, averaging well over 130 a year now, and very similarly, fewer than 5 referrals from primary care a year before IRIS. And what I think it's really interesting to comment on here, and again, please, colleagues from these areas who are on the meeting, comment in the chat box. My recollection from speaking with you over the many years that we've been working together is that between 60 and 80% of all those referrals have been first-time disclosures and first-time referrals. So we know that the IRIS programme and working with our colleagues in general practice is providing access to support and conversations to a whole group of women affected by violence and abuse who've never spoken about what's happening for them before or had that recognised. The third area that we've very recently started with running IRIS is Swansea Bay. That work started in February. We all know what happened in March, so that was somewhat put on hold. And then their training was originally due to be delivered in the spring, happened in the summer, and they have now started delivering locally and are receiving referrals. And I should say that each of these 3 areas, the initial funding came from South Wales Police, and we're very grateful that South Wales Police initially invested in this programme, which now in both Cardiff and Vale and Cwmtaf has been taken on by the health boards. So as I said at the beginning, we very much want this to be a partnership between health and the third sector, but we're very grateful that our colleagues at the police in South Wales initially put the funding in for this. We are discussing IRIS in other areas of Wales at various levels of discussion with them. The challenges that we continue to see are around scale and spread. So how do we make this a pan-Wales initiative and not something that's a postcode lottery, depending on what local commissioners and local priorities can afford and support? And in all of these areas, how do we sustain them? So, it looks great. We've had IRIS in Cardiff and Vale and Cwmtaf for 4 or 5 years now, but pretty much every year or every other year, our colleagues in those frontline services have to go through a recommissioning process, which is very time consuming and very destabilising for the whole programme in terms of women supported, the staff involved and the practices who want this programme to continue. Next slide, please. I won't dwell on this because it's some of what I've talked through already, but what I will flag, because this has been mentioned in one of the previous presentations, is under commissioners, and I guess for clinicians and practices as well. We know that the training and the approach does meet the obligations and requirements for health boards under Ask and Act, and we link very closely with our colleagues at Welsh Government and having conversations with them regularly about what we're doing, what Ask and Act is promoting, and how we can perhaps better bridge and work with them. Next slide, please. So as I come to a close, I think it's really important to see what our clinical colleagues think about the training and the approach. we see light bulbs going on every training session that we run with our clinical colleagues, recognising that this is something that is affecting their patients, and thinking about this as something that they can go ahead and talk with patients about. Now they have a route into referral for them, and they have a what to do, and report that it's a simple process and a simple link into their advocate educator for next step support for their patients, which is very important. Next slide, please. So what I'd ask as a takeaway today is, when we're talking about the costs of violence, and I think we're all aware of this anyway without me sort of saying it, but I'm going to say it anyway, is when we're talking about costs, of course, we're not only talking about financial costs, we're talking about emotional costs, costs to physical health, costs to mental health, and personal costs. You saw in some of those quotes people talking about, feeling like they've gone from a dark place into a brighter future, or seeing a light at the end of the tunnel. What we know is a huge cost of violence is that people lose their sense of self. They lose their themselves in the relationship and in the issues that are going on for them. And if we can support people to recognise and address and seek support for the violence that they're experiencing, one of the very key things that they recognise is that they get a sense of self back, which then means that they can think about their health, and they can think about their next steps for them, their children and their families. So I'd really encourage you to, if you can, raise awareness about evidence-based programmes that can support through health, how and where there are opportunities for commissioning, funding and sustaining programmes, and encouraging conversations about the health response to violence and abuse within local decisions, policy and strategy. Next slide, please. So that's me. I know that the slides will be shared. Please do contact us and get in touch. And again, just to sort of close again by saying, IRISi are the facilitators for this, and it's really thanks to all the work that our colleagues locally do in terms of commissioning, running and facilitating this great work that means that we have the success that we have in Wales, and we look forward to continuing that in the areas that we're running and to expanding it hopefully across the whole nation. Thank you.
Oh, fantastic, Medina. Thanks so much for that. I noticed there's a few questions gone in the chat bar as we've gone through. I've said thanks for everyone who's submitted, but we'll hold off answering those till the end of the webinar, if that's okay. And thanks for the other comments that people have posted with some extra facts as well in the chat bar. So without further ado, I'd like to hand you over to the NHS Violence Prevention team, Fionn and Vicky, who are going to take you through their work. Thank you.
Camera off. Do you want to start speaking? Leave it. It is. It's not. Sorry, we're just. Can you hear us?
Yep, we can hear you loud and clear.
Okay. I don't think our camera's working, sorry, but we'll talk through to you anyway. Okay. Myself and Vicky are here, and we're going to introduce you to what little project we have running at the moment in the emergency department at the Heath Hospital. So you can't see us, can you? No. Oh, yeah. Oh, you can see us. So I'm Fionn, and this is Vicky. We're sharing computers so you can see us both. We just thought it'd be easier, so we're going to present together. Next slide, please. So we currently have a pilot project, and it's the only project running in Wales of this kind. We are a nurse-led initiative, and as I've said already, we're based in the emergency department. We're focusing on delivering advice, support and guidance to patients of any age. So we're picking up patients that present with injuries from violence at any age that come to our department. Regardless of how the injuries are sustained, we'll meet with them and deliver some advice, support and guidance. We work in partnership then with statutory services and third sector agencies, depending on the support needs of that patient. We will plug in and refer on to the needs of each patient. Next slide, please. Thank you. So this is just a little example of some statistics that we work off, and this is what we also share with our staff in the emergency department to give them some motivation and understanding of the importance of our pilot. So as you can see, over 5,000 patients attended the department during January 2016 to December 2018 with injuries from violence. And 60% of A&E attendances were unknown to the police during 2017 and 2018. So one of our initiatives and must-dos for staff now in regards to attendances is reporting. So anybody that attends the emergency department that's present with a knife-related injury must be reported to the police. So we're increasing that intelligence sharing, and that must be shared with the police with or without the patient's consent. And then, as we've already discussed on previous slides, and the colleagues on the previous presentations have said how much the violence is costing our healthcare system. It's almost 47 million short-term costs. We thought we'd give you a little example of one of our patients, for example. He had a 3-week stay here with a knife-related injury that resulted in a total cost of £37,000. So his 3-week stay here at the hospital cost the same salary as a nursing staff. So just by reducing one admission from knife-related injuries could save the NHS a significant amount of money. Next slide, please. So what we do, we try and get our patients to engage and step away from a life that's encased in violence. By doing this, we provide them with information and resources that will help them make an informed decision. We've also noticed that safeguarding procedures have increased and are now submitted in a more timely manner. From previous experience, safeguarding came almost after the initial presentation. So if somebody's significantly injured, safeguarding was almost put aside and that life-saving treatment came first. And unfortunately, some safeguarding procedures were missed. So since our pilot has been in place, we have increased safeguarding referrals and procedures. We also educate medical and nursing staff, so now they're all aware of the need to report all knife-related injuries. And we're also continuously educating so that staff know that the provisions that we provide. So the turnover in emergency unit is quite continuous with regards to our staff. So we're continuously re-educating and spreading the word of the support and provisions we have in place for patients that present with injuries from violence. We've also done a lot of work with raising awareness of the threat that's going on in our city at the moment and in surrounding areas relating to knife crime and relating to crime itself. We do this to try and increase the safety of our staff and patients alike, so that we're trying to reduce that violence. Next slide, please. So these are just some percentages and statistics of our interactions so far. As you can see from this slide, 80% of them are male and only 19% of them are under 18. So prior to launching our pilot, we were aiming at the younger generation, like other organisations in the UK have done. However, Cardiff seems to have a higher age range for more severe violence. So after a couple of months of running the pilot, we sort of opened the floodgates, and we now see and support and assess patients of any age because of that reason. Now, the out-of-area referrals have increased from 6 to 9% over recent months, and we're anticipating that to continue rising as we've recently got major trauma status here at the Heath Hospital. So this means that any significant injuries or traumas are now being flown or brought here instead of their local hospitals. So we are seeing a rise in out of area assault injuries. Now, of the 99 patients we've seen and spoken to that have presented with knife-related injuries, 65% of them have engaged in our service. And of numerous assault patients that we've seen that are anything but knife-related, 79% of them have engaged with us. So we're getting quite a good engagement rate at the moment. Next, please.
Hi, so one of the aims for the project when we first started was to assist in the reduction of reattendance rate to the ED department. What we did is once we'd completed our first year within the emergency department, we looked at 99 patients we'd had in with knife-related injuries or sharp objects, and looked at the engagement rates and their reattendance rates. So as you can see on the screen here, for those who didn't engage with our project, they had a 25% re-engagement reattendance rate for violence, mental health or drug-related medical issues. However, for those patients that engaged with our project, that reduced to 3%. Only 2 of our patients reattended, with violence-related injuries, but have engaged with our team since.
So the idea of this slide is to show that if patients are engaging with our service, they are less likely to come back to hospital, and that then leads on to some savings for the NHS, which is great.
Next slide, please. Okay, so we just wanted to go over some of the outcomes we'd had from some of our patients. From the 419 patients we'd had referred to our team, this slide just highlights some of the support needs and some of the outcomes that we'd had. So what we have noted with a number of our out-of-area patients, including our county lines patients, that when they come into hospital, they have no form of ID, they don't have access to bank accounts, they don't have access to GPs. So one of our main priorities is getting them set up in the local area, and ensuring that follow-on medical support is there for them when they leave and are discharged from our service. Another point is a number of our patients have housing issues. They live in a number of different trap houses or on the streets. So that's we now work alongside housing and try and engage them into now more of a suitable accommodation. As you can see from the chart on the side then, a high number of our patients also have a number of additional support needs, including mental health and drug and alcohol. We also work closely with our psych liaison and drug and alcohol teams to put some additional support in place whilst they're engaging with our teams. Next slide, please. Here you go.
So we just wanted to share with you a couple of case studies to give you an idea of what an engagement looks like in our service and the outcomes of that engagement. So this is patient A. He's a 16-year-old male who presented to the emergency unit with minor head injury. Prior to our project being put in place, this had been seen by a nurse practitioner or doctor and discharged with head injury advice. Our pilot was in place at this point, so I actually went to see this young man after he was medically fit for discharge, and I had a chat with him and his mum. It's developed that this was actually his second admission in under a month with injuries from violence. He had ADHD and he struggled to make friends and acceptable social groups for his age. Unfortunately, a group of older men had identified this vulnerability in him and they had become his friends. So he was none the wiser of the stuff they were asking him to do, but they did start coercing him into minor petty theft and just stealing sort of drugs and food initially, for drugs, alcohol and food from shops initially. However, this did start escalating to the point where he was asked to steal quite an expensive bike. He did as they asked, as he thought this is what friends do. He stole the bike, but he went home and told his mum. His mum rang the police. The police intervened, and as a result of the police being involved, he got beaten up by this group of boys. So after finding all this out, we submitted him off for his own safety reasons. We learned that he hadn't been going to school for over a month because of fear. So we worked alongside the school with a third sector support agency to re-engage him into school, which he's now back in full time. He continued working with our third sector organisation to develop his communication skills and to improve his social skills. So he's making correct friendships and more appropriate friendships. He's no longer being groomed by the gang, and he's not reattended our department since. So coming from 2 visits in a month to not being back in several months is a nice outcome for us.
Next slide, please. So the next case study is a 25-year-old male. He attended with us self-inflicted hand injuries from punching a wall. So that's another avenue that our team picked up. We noticed a large number of patients attending the department with self-inflicted punch injuries. What we did then is we did a back study and noted that a number of them show emotional regulation issues. So we started picking them up as referrals also. And this man is a perfect example of this. So he came in for his 4th admission in 2 years for self-inflicted punch injuries and assault injuries. And prior to our team being up and running, he would have just been discharged with no follow-up. I spoke to him in department and discovered that there was a whole backstory in regards to domestic violence from his stepdad and where he was sleeping on his sofa. During support and his risk assessment, we also noted that he couldn't read or write, so was struggling to fill out housing forms. So I supported him in community to complete his housing support options forms for floating support. So now he has a support worker, has since been rehoused and is now back in employment, and thankfully has not been back to the department since. Next slide, please. And then the last of our case studies is patient C is a 17-year-old male who came into the department with a number of knife-related injuries following a stabbing. On admission, he couldn't quite fathom why he'd been stabbed. However, following support from us and our third sector community team, he went on to disclose that he had actually been dealing coke and cannabis in the community. So we worked alongside safeguarding. He engaged with the police and a successful prosecution was then obtained. We also supported him and his mum with emotional and mental health issues following the assault. His mum really struggled, so we then referred her for some additional community support. And then he then later disengaged after completing his third sector support and is now back engaging in community and has an form of employment. Next slide, please. So this next slide is just a brief outlay of something else that we're involved in the department. We here at University Hospital of Wales are the only hospital in Wales to have a health independent domestic violence advisor. Women's Aid did a study previously, you can see on here is Yasmin's story, showing the effect and cost savings that a health IFA can have if based in the emergency department, and therefore early intervention when patients come in. When we first went into lockdown, concerns were raised in regards to an increase in domestic violence. So what we did, we changed our policy within the department, and instead of a targeted approach, so previously staff would only ask domestic violence questions if they were concerned, if the disclosures were made or there were concerns in regards to injuries. However, as lockdown began, we then started doing routine inquiries. So we asked all patients attending the emergency department domestic violence abuse questions because they were alone, it was a safe environment. We weren't allowing patients to come in with anything else into the department. And as a result of this pilot scheme, our referrals, not thankfully, but they went up 130%. So now we have 2 health IFAs supporting us in the department to support staff with all the domestic abuse referrals. And that's it, thank you.
Thanks, everyone. Please feel free to email us if you have any further questions. And we can answer them at the end as well, obviously.
Fionn, Vicky, thanks so much for that input. That's fantastic. Thank you. And some really fascinating details in there, including the case studies. And you know, I think your summary there that just a couple of readmissions of patients avoided would actually fund the entire intervention. So that's very impactve stats. So and I know that in the very near future there's going to be a sort of formal evaluation conducted of the service as well, Fionn and Vicky, which I think will, you know, that independent evaluation will also give some even more details around the benefits you're bringing and helping to keep people safe. So thanks so much for that. There's just one, so just in terms of questions that people have submitted as the webinar progressed. The first question, Madeline asked one for you and Fionn and Vicky, about what does it mean to engage with your service. So I know you provided some details in the presentation, but in terms of people engaging with you, what process do you actually follow?
Hi, yeah, thank you for pointing that out. We don't actually go into much detail about that in the beginning, do we? So engagement with us involves seeing any patient that presents to the department with violence-related injury that's not domestic abuse. We'll then go and meet with the patient if it's still an inpatient. Inpatients do take care of discharges, and we will just have a talk with them, identify any vulnerabilities through a risk assessment, and we'll then look at services available to help support them. So in some cases, particularly our youths need emotional support or anger management, and then other patients, as Vicky pointed out, need support with housing, and we'll just tap into the services that are available then and refer them on to support services for whatever their vulnerabilities are. If they do stay in hospital, we do keep them as a caseload to try and build up some rapport with them, particularly with our patients that are in deeper criminalities and deeper into the system than others. We try and sort of build up that good rapport so they trust us more, and then they're more likely to engage in support services after discharge.
Fantastic, thank you. If anyone does have any other questions, please do ask them in the chat box, and I'll carry on with some of the ones that have been submitted already. So from Ree, I think this is for you, Medina. You know, a common issue here around struggling to secure funding for interventions that we believe work. Just one question is whether you'd have any advice around funding at all.
Thanks, John. And sorry, I was just in the middle of replying to that, so I've put a reply on the bar as well.
Thanks.
Yeah, it's a perennial challenge, unfortunately. And I'm wondering whether, you know, in response to that specific query in your area, Ree, maybe chatting some more with people in the IRISi team and perhaps with some colleagues who are already running IRIS within Wales, some of those who are on the meeting just now. I think the things that we're seeing in terms of the pandemic sort of working in our favour, that's not the right way of putting it at all, but we know that the issue of domestic violence and abuse is pretty much daily in the news and has been since the start of the pandemic. So an opportunity, I think, that this awful situation has given to us in this sector is that the issue has been brought much more to the fore. People are talking about it, people are much more engaging with it. We've also got the domestic abuse bill going through the Lords. We've got the Home Office statutory guidance. We've got all of the great work that, you know, Wales really leads the way on in terms of legislation, the Ask and Act agenda and so on. So we very much promote that in our commissioning advice and business case guidance to areas to say, you know, how can IRIS help to answer some of the questions that your area is seeking answers for? So, you know, what is your local policy? What are your local procedures? Have there ever, unfortunately, been any domestic homicides? Is there any concern about communication between health providers and the specialist service? Are there any gaps through which people are you know, sadly falling? And I think in terms of engaging with clusters, I mean, it couldn't be a harder time, really, could it? You know, on the one hand, we are able to respond to a need, but we need people to recognise a need and give us time to work with them to do that. And right now, you know, across the board, the three groups that we most commonly work with at IRISi are patients, specialist providers, and general practice teams, and each of them are under huge pressure for obvious reasons right now. And within health, this time of year, you know, without a pandemic, is flu time, you know, a time when staff are off as well. You know, healthcare professionals are, you know, get sick too. So I think it's challenging. I think there are ways that we can support, which we're very happy to do. And we have packs of information and ready-made business cases that we can support you, we can offer in terms of templates.
Thanks so much, Medina. I think if we could just stick with you just for a second, Medina, because there was a number of questions on a similar theme around whether you offer a service for men as well as women, whether IRISi helps men as well as women, whether it's been effective in uncovering honour-based abuse, such as FGM and forced marriage, and also whether it's been effective with identifying victims who are over 60. So whether you could answer those.
Yeah, absolutely. Thank you, John. And thank you, Jackie and Amy. I can see that you've responded to some of those as we've gone through with some very Wales-specific data, which is brilliant. So in the order that I noted them down as the questions came in, so Julia asked about the demographics of age. So across all of the programmes that we run, England, Wales and Northern Ireland, 8% of referrals are for women aged 60 and above. And as I think Amy mentioned, you know, we see women up to their sort of late 80s who've perhaps been in relationships for 60 plus years, you know, very violent and abusive marriages. So yes, we collect a whole range of patients. If we look generally, the average age of service users across the 10 years for which we've been collecting data is 39 and a half years. Nearly 14% are aged 50 to 59 and 8% are aged 60 and above. So we know that we see an older demographic coming through general practice for support and disclosing than we quite often do in our specialist services. So yes, we do feel that we're reaching an older demographic. We work with some organisations like Solace Women's Aid in England, and they run projects specifically and responses specifically for older women. So I can certainly offer links to that, Julia, if that's of interest and help. Shyam, in terms of FGM and honour-based violence, as Jackie pointed out, BAWSO, as partners who we work with in South Wales, have specific expertise around this, and forced marriage, so-called honour-based violence and FGM are certainly things that we talk about, discuss and train on in our training. In our national data, I'm slightly embarrassed to say we don't at the moment separate out each of those three areas and report on them separately. Bunched together, they're very clumsily classed as other, and about 10% of the 13,500 women for who we have data are affected by and do disclose FGM, honour-based violence and forced marriage. We are piloting, well, we have piloted an adapted IRIS in sexual health services, and we're looking for early adopter sites to run that outside of a research trial right now. And I'm wondering whether, when we are more active within sexual health, whether we may be perhaps supporting our colleagues and clinicians working in sexual health, we might see higher numbers of FGM and honour-based violence coming to the fore. So in a nutshell, what I'm saying is, yes, we do train around this and we do see it. we need to get much better and improve on how we collect the data and how we report on it, and that's something that we are aware of and are working to improve. And talking about perpetrators and support for men, we have 3 referral pathways in every IRIS service that runs across the UK. The evidence base that we have for IRIS at the moment is that it's effective for female patients aged 16 and above affected by domestic violence and abuse. So that's the core work, the core programme that we offer. We also have a referral pathway for men affected by domestic violence and abuse and for perpetrators of domestic violence and abuse. And we discuss this and train around it in the training that our partners deliver in practices. The issue with those last 2 referral routes is how few and far between specialist services are for men as victim survivors and for perpetrators. So the care pathways that are developed within each local area are very much contingent on what the services are available locally, and sometimes this is to a national helpline because at the moment that's all there is, and sometimes it's to a UK-wide helpline because again sometimes that's all there is. Just to finish off on that though, there is research going on right now into both of those areas. So the not very imaginatively named IRIS Plus is a programme of research that's going on with some of the same research partners at Bristol University who developed the IRIS programme, and that's to look at what an adapted IRIS programme would look like to respond to men as victim survivors and also to respond to children as victims in their own rights, either as victims and survivors who are living in a family where there is domestic violence and abuse, or whether they are experiencing it within their own relationships as young people. And there's also a piece of work going on to look at perpetrator programmes and best practice work for perpetrators. Some of the IRIS Plus piloting is happening in South Wales. It's happening in general practices in and around Cardiff. And Jackie, who's on the webinar today, would be able to give some more detail about that locally. But if you look on the University of Bristol website and type in IRIS and a plus sign or re-provide, as it sounds, you'll find out more information about both of those programmes.
Thank you, Medina. That's fantastic. And I've just got a couple of questions for Fionn and Vicky. So Fionn and Vicky, there was a question on there around whether you offer a service around domestic abuse. The author of the question thought that you'd said you didn't, but I just wondered if you could clarify whether that is within scope for you.
Yeah, of course we can clarify. So myself and Vicky don't pick up domestic abuse injuries ourselves, but they are picked up by the 2 health advisors that we mentioned at the end. So they're now in place and we wouldn't have the capacity to pick up domestic abuse as well as all the violence related injuries that we see and cover.
Oh, thank you. Thanks very much. And then the other question, obviously there's some other models in hospitals such as Red Thread, and obviously yours is a nurse-led approach. Just wondered whether you thought there was benefits in terms of it being a nurse-led approach as opposed to another form of provision in the hospital.
Yeah, of course. So we've identified a few benefits really of being nurse-led. One would be not being limited to an organisation's criteria. For example, we were quite easy and able to change the age category that we work with because we're not governed or restricted by any age limits. And we also don't have a limit or a minimum risk rate. So we can work with any patients of any risk. Even if there's no risk, we can offer them basic emotional support, for example. Secondly, we offer that holistic approach. So being an emergency unit sister myself, I can give the patient advice on recovering from their injuries or any questions they have whilst they're in hospital. So it's sort of being more holistic and giving that greater package of care to our patients. But our most sort of significant benefit of being nurse-led is that throughout COVID, throughout lockdown 1 and 2, we were able to continue with our programme. We were continuing our support, and we continued with face-to-face interventions as we were based in this hospital throughout all of COVID, which is great because our assaults admissions and the numbers of admissions that we saw didn't actually drop through COVID. So we were still able to provide that support service, which was obviously necessarily needed throughout COVID.
That's excellent. Thanks ever so much, Fionn and Vicky. And just another question, whether you've got enough capacity in terms of obviously just being the two of you, how do you manage?
Yeah, we manage. So as I said during the PowerPoint, we do prioritise inpatients. So inpatients come first. That includes inpatients in A&E, so they might not be admitted, but they would be prioritised over our phone call consultations. Between us, we're managing the workloads. Our caseloads are reasonably small, so we only keep no more than 10 patients on our own caseloads because many of them get referred on. So some interactions may only take half an hour, others take several visits or several phone calls and weeks and long-term interventions. So they tend to stay on a caseloads a bit longer, but we don't have a waiting list at the moment. The only wait that would happen is if we were seeing an inpatient, the discharge patients would be waiting for our phone call, but it's no longer than a day or two.
Oh, thank you very much. Thank you. There was a very specific question around the recording of today's webinar. That's going to be available on YouTube. The link for that will be circulated with the papers, or rather the presentations from today. And there'll also be a link off our website as well. And I've posted the Violence Prevention Unit website in the text bar in case anyone hasn't seen it. There was just one other question originally. I think it was answered really, Lisa, by you, but it's probably just worth reiterating for everyone. It was a question around whether your costs of violence to the NHS, whether it picked up some of those secondary costs as well, such as prescription charges. So I just wondered your views on that.
So I guess in relation to prescription charges, no, we weren't able to look at that as one of the cost components. So, for example, for the counselling element that we were able to cost, we looked at the cost of somebody providing a counselling session. And then with respect to primary care, again, that was the cost of a GP providing their time. So no, we agree that it's an important cost component, but we didn't have the information to hand to be able to cost that out. So we talk about the limitations a bit more extensively in the full report. So just noting that we probably think this is a bit of a underestimate of the total cost, but it does give us that indicative kind of burden of violence on the health system.
Absolutely. Thanks, Lisa. That's great. Thank you. Fionn and Vicky, there was just one other question around whether you've got a written agreement between A&E and the police for any extra training for staff regarding the reporting of all knife injuries. Now, I know you've actually been doing work with some of the staff in the hospital as part of your role, haven't you?
Yeah, we've done quite a bit of training to encourage referrals and informing the police. So we've trained staff to try and encourage all patients of crime to report to the police, but we can't force anybody unless it's knife related. Now, it's written in the GMC, which is the medical guidelines and medical counsel for doctors. So it's all doctors' responsibility, regardless of where they're working, not just here in our department. It's their responsibility to now report to the police any knife-related injuries. So we do encourage staff to be aware of that, which they should be anyway, as it's part of their governing contract. And it's also in discussions with the Nursing Governing Council to become a contracted a requirement of their practice to report all knife-related injuries also. So even though there's nothing written between us, it is a requirement of a registered doctor to report.
Thanks very much. That's great. Thank you. Medina, did you just want to come in briefly on the prescription question?
Thanks, John. Yeah, just really quickly, and it'd be great to chat more offline with you about this, Lisa. It's something that we've tried to collect over the years. We didn't collect it for the trial, and outside the trial, we thought it would actually be quite straightforward to ask clinicians when they referred in a patient, what have the prescriptions look like 6 months before the IRIS referral, and what do they look like 6 months afterwards? Firstly, it's really difficult to get, because clinicians are very busy people, it's really difficult to get that information. And secondly, if we do get it, it's really difficult to separate out the impact that the advocacy and IRIS has had and the impact perhaps that other things have had. Like there's lots of noise that goes on in people's lives, and what has an impact on what can be quite difficult to separate out. I'm determined and absolutely sure personally that there is an impact and an effect. We know from case studies that and talking with women that particularly medication around anxiety, depression, sleeplessness reduces when they're getting support that they need that's around the violence and abuse. But in terms of anything that would be statistically viable, we haven't found a way yet of finding that. So if anybody on the meeting is able to support with that, we'd be really interested. And Lisa, I'll definitely check in with you more about that as well. Thank you for that, John.
Oh, thank you, Medina. And so I'm just conscious of the time. This is drawing our session to the close now. So I'd just like to thank all of you for attending today. Really good attendance, and I'm really grateful for you giving up your time at the webinar today. Most importantly, though, I'd like to pay special thanks to our presenters today for such fantastic and insightful inputs that they've given to us through the course of this afternoon. So diolch am eich mewnbwn heddiw. Thanks for your input today. And normally I'd wish you a safe journey, but you know what I mean. It's been a pleasure having you join us today, and thank you for your great questions as well. And look forward, most importantly, in our core role in helping to prevent all forms of violence across Wales. Thank you. Diolch yn fawr.